All right, well, it's 4:02. As promised, we'll get started. So good afternoon to many of you. Also, good morning and good evening. I think there are a few people joining from across the globe, or at least the region. My name is Andrew Stalker, and I'm head of MetLife's employee benefits business for the Gulf. Let me be the first to welcome you to MetLife Gulf's Thought Leadership webinar series entitled Post-Pandemic Claims Are on the Rise. This webinar follows up our claims data webinar from earlier this year, in which we looked at data showcasing COVID claims 12 months following the initial onset of the pandemic. MetLife's webinar series, such as this one today, focus on delivering informative and topical thought leadership that impacts a broad population of our region and the world. When the pandemic began in early 2020, there was an initial lockdown, as many of us remember, to reduce the overload on the healthcare system. At the time, MetLife presented an actuarial view of what we would expect in future claims and what those might look like as a result of the lockdown and the pandemic more generally. We presented a view at the time that a rebound of utilization would exceed normal utilization between the months of August of 2020 and the remainder of the year. Then it would normalize by the beginning of 2021. We also raised some concerns that the severity of diagnosis and prognosis could worsen, resulting from the lack of regular follow-up and screening that would have occurred during the months of March to late 2020. In most instances, we got it spot on, and our predictions that we shared came true when we looked at a view in early 2021. 6 months later, and almost now 18 months following the onset of the pandemic, there are some aspects of the post-pandemic environment we did not necessarily predict to linger or, in some cases, to emerge. By now, it's likely you've either heard or read the headlines. From the Gulf News earlier this year, medical premiums are on the rise, where distinguished colleagues from the insurance community raised the warning signs of claims beginning to be 25% over pre-COVID levels. A quote in that article shared the following: "There's no way the overall cost of medicines can be brought down. It is the same with consultation fees and specialist diagnosis charges. So medical premiums have to reflect this." A similar article published in September of this year, just a few weeks ago, by the Middle East Insurance Review, stated that medical loss ratios would in fact rise during the second half of 2021 due to the normalized claim activity. Although the storyline and the underlying claims performance of insurers does raise concern for managing to our clients' expectations, understanding the data and refining the strategy to mitigate those drivers is well within reach. By combining data, preferred network alignment, tailored benefits and coverage, and, very importantly, education, employers can proactively address changes we have seen in provider and member trends, with the goal of creating more sustainable options into the future. So that brings us to today, and with that goal in mind, I'm joined by Dr. Shafiq, MetLife's head of claims. And over the next 30 minutes, Dr. Shafiq will update you on key trends in the medical claims performance before turning it over to some Q&A. We will also highlight several examples of options that could be applied to trends seen in the performance of you or your customers' policies. As a reminder, although you can ask a question verbally, you can write one. And you'll find that either asking a question or using the chat function to ask a question in the box at the bottom right-hand side of your screen during the presentation will allow us to have those questions answered during the Q&A section. So without further ado, I'll turn it over to Dr. Shafiq. Thank you, Doctor.
Thanks, Andrew. Thank you very much for inviting me to discuss on this very important topic itself. And the way it has evolved, it has become very interesting as well. And in the next couple of minutes, we will see why we are calling it very interesting as well, because a lot of things we will understand are within our hands as well if we want to avoid it. Now, as Andrew mentioned, and he has quoted for a couple of things from the market as well, outpatient claim cost is on the rise itself. Now, let's look into some of the driving factors which are revolving around it. If we look into the top reasons, although there are going to be more reasons than that, but if we just look into the top 4 or 5 reasons around it, you have what we are going to cover today is onto the top 5, which will showcase, for example, we have seen a shift in the choice of the member going to their preferred hospitals versus the clinic. And in the next slides, we will understand how does this have an impact on us. We also see that pre and post pandemic, there has been a change in the disease mix. So the disease prevalence has been changing. And interestingly, we will also understand that how is this disease prevalence in pre-COVID and in post-COVID area, how is it going to have an impact on us? There has been some very good regulatory changes as well, and these were good for us, although it has an impact, but we will understand that how this has an impact on us as a community. There has been a shift in the physician's preference, and we all know that it's a very open market. There are no restrictions, but we will understand that how will it have an impact on us. And last but not the least, the most critical one is the medicine utilization. How the prescriptions have changed, how the disease mix have changed, and what impact is it bringing onto the medicine cost. So these are the top drivers on which we are going to discuss, and we'll see how each one has an impact on us. With this, we're going to move to the next slide, which is going to talk about the members' behavior. Now, since COVID and pre-COVID and post-COVID, in both the era, we are seeing a change into the members' behavior. And what does it mean? Previously, into the pre-COVID area, what happens is that the minor ailments, especially in relation to, let's say, for example, respiratory tract infections, your flus, fever, some musculoskeletal minor conditions, people used to go to family doctors, to clinics to get themselves treated. Now, post-COVID, what we have seen is that this choice is actually changing. And how is it changing? Now, members are going more to the hospitals to get their minor ailments treated. Now, we need to understand what's the difference if somebody goes to a clinic versus somebody goes to a hospital, where both of them are within the network and it's open as well. The difference is a lot. If we just take the 2 top tiers from a MetLife perspective, the gold and the VIP card members, we see that almost 11% of the population has moved from clinics and now going to the hospital to get treated for these minor ailments. Now, in hospital setup, the way the protocols are different versus a clinic, and these minor ailments are getting treated more aggressively. Does this mean that this is the right form of treatment? And the answer is no, because not every disease requires to be treated too aggressively, especially the acute conditions. That's why there is an outpatient cost increase. From our data, we see that there has been an impact which could be in single digit, but overall, when we are going to look into the picture towards the end, it could go towards more as well. When you are in MetLife, what we do is that we understand the variance of the cost between clinics and hospitals and different network categories. And this is where we provide you with the insights so that you can take an informed decision itself. These can be monitored. We can provide you data around each provider to ensure that you are well equipped to look into your plan design itself, and without having any impact onto the health outcome, you can choose the right network for yourself and for your community. And not only the right network, but also you can pick and choose from different network itself. So there is a flexibility around it, which provides you complete data coverage itself. So moving on to the next slide, which is going to talk about change into the disease prevalence. Now, this is a very interesting slide, and this will bring a lot of eye openers. So in this slide, you only see one yellow bar, and that's the most interesting one. So those who have looked into the data into the pre-COVID times, the topmost disease which always used to come used to be upper respiratory tract infections or respiratory tract infections. Now, post-COVID, if you see, it's towards the bottom. And in fact, if you see it more carefully, it has gone towards negative. And this is just a data comparison from the pre-COVID itself. Now, why did this happen? Because the whole environment was changed. So children were not going to school, people were working from home, there was nothing, and people were very conscious to ensure that nobody gets an upper respiratory tract infection. And this is where we were taking care of ourselves too much. Now, with this, what has happened that yes, the upper respiratory tract infection cases have gone down, but then other diseases have emerged. So now, which diseases are on the top? If we look into those conditions, those are our endocrine and metabolic diseases. For example, diabetes, for example, hyperlipidemias are now on the top. The second one, which is catching our attention, is our musculoskeletal conditions. So people are having more of back pains, neck pains, and the best part of these conditions are majority of these are related to lifestyle changes, and these are pretty much preventable itself. Now, in MetLife, we provide regular insights to you in relation to the disease prevalence itself, in relation which disease are preventable, and we also provide you solutions how you can control these diseases, as we have programs in place where you can get enrolled and you can go up with your lifestyle changes behavior, and which means a more healthier population. Now, we have always heard about that healthier population always gives better outcome to the employers as well, and that's why it's in the interest of the employer that the population remains healthy. And in the next couple of slides, when Andrew will take it up, we will provide some solutions around all of these things which we are seeing in the post-COVID era itself. The next slide is another interesting one, because that slide is going to talk about how, I think, John, we are on the same slide. We can go to the next one. All right. So the next slide is more about compliance itself. So during COVID, the regulators came back, and thanks God for that, that there was a mandated set of protocols to be done for not only for the COVID patients, but also for the patients where there was some symptoms which were mimicking like COVID. So either COVID-like symptoms, or anything which was in relation to that. Now, definitely for those conditions, we do see that the labs were and radiology and some of those things were increased, which had an impact onto the cost. But on the other hand, with this maneuvers, we are all able to come back to our lives quite normally, versus some of the other parts of the world which are still struggling. MetLife was very supportive to cover all of these tests. We were supportive of the regulator because we believe that it is going to bring a positive outcome to our population. And now we are experiencing the same as a result of that. If we can go to the next slide, because the next slide is something which has always been very close to me. Now, it's an open market, and here the patients on their own decide, what are we going to do? So a lot of time it happens that as we do not have the setup of the family physicians, people decide on their own, where am I going to go? So if I get a pain onto the back, and I decide, okay, it looks like an orthopedic problem for me, I just book an appointment with an orthopedic, end up, and the orthopedic doctor, after seeing me, after doing a couple of tests, will tell me that, listen, you have a good news and a bad news. Good news, you don't have an orthopedic issue. And the bad news is, it looks like you have a nephrology issue. So you need to go and see a nephrologist. So deciding on your own who is the right consultant for me is not always going to give you a healthier outcome. As we have seen in a lot of cases, and we have tons of examples, headache, people approaching a neurologist and then finding out that it was only and only due to an increase into the hypertension. From our data, what we are seeing is that people have started going more towards consultant versus going to the family physicians, which are generally called as the general physicians, or to the specialist. 157% increase into that could be attributed to the fact that people have changed the behavior and they are going more towards the hospitals, and there they have more consultants versus the family physician doctors itself. And it has an impact onto the cost because the way the consultants approach to the disease is totally different. And at times for these minor ailments, it's not going to give you a best of the healthier outcome. Member education has been critical. MetLife has been extremely vocal about it over the years. It has been an open market, and that's why it hasn't gained a lot of attraction that this change should be brought. However, if we look at all major healthcare systems across the globe, whether it is in UK, USA, or in other parts of the world of Europe, everywhere there is a mechanism where people pass through a family physician control itself, not because to cut down anything, but to ensure that they are able to cater you to the right consultants, because triaging is a critical part of medicine, and triaging really helps you to cut down the wastage from the system and unnecessarily going to the consultants itself. So this is bringing in an impact of around 1%. Overall, if we just take this in isolation, but on an overall picture, there will be a bigger impact versus what we are seeing here just by changing the physician preference itself. Now, if we go to the next slide, the next slide is the most interesting one and is a result of what we have seen up till now. Now, in the last couple of minutes, we have spoken about how the choice of members have changed going to hospitals. We have spoken about how members are changing from going to family physicians to directly consultants. And we have also seen, remember, that there has been a change in the disease mix. So we saw that upper respiratory tract was going towards negative, whereas the lifestyle conditions and the diseases were going towards the top itself, along with the musculoskeletal. The drug utilization or the prescriptions are no change from what we have seen up till now. So this slide is telling us that our asthmas, our allergies, our cold, cough, and flu, and our infectious diseases. And majority of these infectious diseases, whether bacterial or viral, are falling into the category of upper respiratory tract infections itself. Those are going towards the decline, and we see a negativity towards that. Whereas on the other hand, what we are seeing is that your diabetes, your cardiovascular conditions, and the use of vitamins and minerals are on to the rise. Although we all are aware that in this part of the world, the vitamin D deficiency is always there, and a lot of people, along with the COVID, there was always an increase of having more and more vitamin D to ensure that the immunity goes strong. But along with the vitamin D, we also foresee that there was a lot of other vitamins and nutrients which were being taken, which probably are not required for your body, because remember, your body is already generating some of these which are enough for you. And anything which has been taken in surplus, it's very important to understand that it will be excreted out from the body. So it wouldn't be really required, and the body is not going to absorb something extra. So despite of the fact that some of the vitamins, for example, vitamin D, if it goes into the surplus, it might also have some side effects. But despite of the fact, if we ignore that, still unnecessary vitamins are not going to help us apart from that. Now, coming to the other conditions like diabetes and some cardiovascular conditions and hyperlipidemias, what we have seen that the patients who were previously suffering from the same conditions and now are getting treated more aggressively, which simply means that if someone was taking one medication for the hypertension, is now taking two medicine to control the same hypertension. The aggressiveness to control it is not healthy at all times. It's healthier to ensure that you are just taking the appropriate number of medications and not necessarily extra medication itself, because that's not healthy for your body. In MetLife, we have a state-of-art pharmacy benefit management system, which can control the drug-to-drug interaction. It can also control an early refill. And the whole idea is that we keep the prescription cost under control. So that's what we do in MetLife in terms of prescription utilization. And this is the kind of a behavioral change we have seen post-COVID itself. Now with this, we'll move to the next slide, where I'm going to hand it over back to Andrew for his comments.
Thank you, Dr. Shafiq. Just a few comments, actually, and there was a question that we got in, so I want to raise, actually two questions I want to raise before I move into my side of the presentation. But I just wanted to confirm, because it was worth commenting on this, that the data that you just saw illustrates pre-COVID and post-COVID. So Dr. Shafiq, if you don't mind just referring to the time periods you used here in your analysis. Again, this is not what we've seen since the beginning of the pandemic. This is actually comparing what we call sort of post-pandemic with pre-pandemic, correct?
Thanks, Andrew. I think this is a very important question, and I should have addressed it. So yes, so the data which we took is that when we are talking about pre-COVID, we are talking about mostly 2019 and just a Jan-Fab for 2020. But remember, COVID has hit us somewhere in the month of March, and later on we had some lockdown period. So this is the period which we have not taken into effect. When we talk about post-pandemic data, we are talking about taking data somewhere from September, October onwards itself, and then taking it up to 2021. Because if we are going to take the data of that time, it was an atypical time. There was lockdown. The government has taken measures that most of the surgeries were not allowed if it was planned surgeries. Similarly, no one was allowed to go out from the hospital even for their normal ailments. So there was a suppression which we have seen, and this is exactly what we did into the last webinar itself. So that's the definition of the pre and the post-pandemic data.
Great, great. Thanks for the clarification. I think the other important point, and we'll talk a little bit about this in the next few slides, is around education. You mentioned it as it relates to do our consumers, do our employees, do their families know about the cost associated with providers and the differing cost associated with, as you mentioned, GPs, specialists, and consultants. And I think that's a really important point that we'll continue to talk about throughout the presentation. Here was one of the questions, and it actually relates to your last slide, which was about medicine. And you mentioned the PBM system, which helps on many fronts address cost, but it also addresses, as you mentioned, several components of managing the right prescription and the right dosage, and ensuring that there's not medicines that are going to contradict or cause challenges with a patient's health. But just generally, the question came in related to medication costs. The question was, what data is available? How granular can we get with data? And what can employers do to address the cost of medicine?
Thanks, Andrew, for the question. So in this part of the world, the cost of the medication is being regulated. So there are regulators who look into the cost, and the regulator is the one who is deciding what is the cost of this. So unlike some other parts of the world where cost of the medications can be changed easily, here in this part of the world, it is quite regulated. Now, coming back onto the question that how granular is our data? Our data is deeply granular in the sense that we can go up to the conditions, that we can tell you that how much have we spent on, let's say, cardiovascular or musculoskeletal conditions. So how much has those prescriptions cost us in total? We can go more granular to tell you that by each category, an average cost of prescription was how much. And we can go more granular to tell you that what are the costs which we have taken onto acute versus chronic conditions. And then we can go more granular to say that out of those chronics, which are the ones which are related to lifestyle conditions and which are the ones which are not related to the lifestyle conditions. And if we want to go more into that, we can also go by the number of strips and the number of tablets being given around it. And we can also dig down the data by provider. We can also dig down the data by doctor itself. And we can also dig down the data in terms of the category of the doctors, whether the GP, the specialist, and the consultant. So the data itself can be driven into different ways and means, and we have every slice and dice of the data, and it's critical because if we do not have this in-depth of data available, we wouldn't be able to really bring in the solutions and the control we would like to.
Yeah, great, thank you. And it is a great question. We don't cover it in the next 3 slides. I actually stay away from medicine and generally just talk more about OP. But certainly what we can do for employers is make this data as granular as one needs, and we're very comfortable providing this information to help not only develop the right plan design, whether that be generics versus brand medication, develop the right copay structure to ensure that we're not impacting members negatively, but we're driving the right behaviors, and also be able to identify what the cost is associated with the various disease conditions that are prevalent within a population. So again, this data is there, and I think your point is this can help us really drive the right outcomes. The second question, just before I get into my slides, is more a general question, and we get this a lot, and I appreciate the question, and that's around how MetLife manages provider behavior. Clearly, you talked a lot about member behavior, but in there, interwoven was provider behavior. And so what measures does MetLife take to ensure the proper provider control? That's the question that just came through.
Brilliant question, and I think thanks for bringing up this question, because we didn't touch into it, because probably this has become like a BAU and it's part of our DNA. So MetLife has a very robust provider performance analysis mechanism done at different levels, but I will just touch base on the 2 major ones. So we have a team, network team itself, the role of the team is to look into the provider and to understand what's the behavior of the provider, what's the trend of the provider. Again, we've worked onto the data to make it very, very meaningful for us. And what we have done is that we club up all the different services which are being done whenever a patient visits any doctor or a provider. So different services being done, whether it's a lab, whether it's a radiology, a pharmacy, we club it up all together and we convert it into an episode so that we can understand the actual meaning of how much is that episode costing us itself. This is being done to ensure that we understand that from a doctor's perspective, from a provider perspective, how the trends are going on. And in case if there is anything which is deviating, we have a mechanism, we have a team who is always having these discussions with the providers in terms of the partnership to explain that how we are seeing this data, how the things are changing, and how can we work together in the best interest of the health of the insured to make sure that we bring things back to normal. Now, apart from the network, we also have a very special unit which is called as the fraud, waste, and abuse unit. What does this unit do? This unit also looked into the provider, and they have several metrics around it. They look into the providers to see if there are any outliers. We have a state-of-art system which gets flagged these cases which are over and above the medical norms. These go to a special investigation unit, which is called as SIU unit. We looked into these cases itself, and then we also, apart from deep diving into these cases, we also perform on-site audits of the provider. Keep in mind that apart from all of these, we do have a robust pre-approval mechanism. We have a team of doctors which are called as case management team. They are always onto the ground. They're talking to the doctors to understand how we can give the best possible outcome for our patients. We have a clinical audit system which is incorporated into our system itself, which works on to the technical ICDs and the CPTs itself to ensure that every claim is being looked into it meticulously and a decision has been given to the human to make sure they take a very informed clinical decision itself. And the whole idea is just to ensure that we cut down the wastage and abuse and provide the best possible thing for our insureds.
Thank you for that answer, and I'll just quickly comment on that as well. Certainly my experience has been that the traditional approach to managing cost or managing providers is through the mechanisms Dr. Shafiq just highlighted, which would be the network team and network metrics around maintaining the right balance with providers from a cost perspective. And then the second, of course, being oversight from a fraud, waste, and abuse perspective. I do think that the future is going to look more like tripartite partnership between insurer, payer, provider, and the employer to design preferred network relationships and to design the right value-based outcomes for the claim performance and the member's experience. And I think we're starting to see some of that emerge in this market. And I think this will be an important part of defining management of future cost as we start to see the UAE specifically look a lot more like those markets that have gone through a 10 to 15 year maturity of their healthcare systems. And so that's certainly something to keep an eye out. Okay, just staying on this slide for a second, I'm just going to comment as we move into the next section. There are never enough layers, as I see it, of the onion to review when it comes to evaluating claim performance and determining the best approach to mitigating rising claims performance. And we just talked a little bit about that just a minute ago. With claims funds typically hovering around 85% of the premium a customer pays, the plan and the network design, the provider management, as we mentioned, the overall health of the population, and member behavior all play into managing the cost of a claim fund over time. And so it's a complicated rhythm, but all of these components play a part in managing down to a very minute level the performance of a claim fund. And each customer, as they say, or each case specific is very different. So over the next few minutes, I'll cover a few unique ways we've used data to support improved outcomes of claim performance, all while supporting the overall health of our member population. So I'm just going to give a bit of background on the next slide here. In the traditional sense of claims management, when we think about managing a claim fund, the plan design and the network access available to the member is going to drive a significant portion of the risk and therefore the cost. So those are obviously on the top left and top right hand side of this puzzle. Things like network access, sublimits, and maximums make up the most of those, right? In addition, techniques like member copay and our overall member health also play an important role in how a claims fund will perform. Generally, a healthier group is not going to have as much weight on the claim fund, and certainly a member's share in the cost is going to potentially impact not only how much cost the claim fund accepts, but also the behaviors of the member. And so what we see is traditionally these may look like the different approaches that many developing healthcare markets have used, but also have struggled now lately in terms of the cost of premiums, and certainly responding to rising premiums. And so those are the areas or the techniques that remain an important part of managing a claim fund performance. And now with the refinement of new data points, it's allowing us to more target managing claim performance, and in some cases, aligning design to reflect less punitive responses to managing the claim fund, whether that be copays or plan design changes. And so in the next slide, you'll see, in general, we are deriving through new enhanced data-driven approaches the ability to reimagine healthcare plans that deliver better care, happier customers or happier consumers, and lower cost. And let's remember that healthcare, when we think about the patient journey through a healthcare experience, is rather much a black box. It's probably the one industry or one consumer product that the consumer knows very little about what happens, and they rely heavily upon the inputs of others with respect to how they seek care. Very different from how consumers use other types of consumer products today. So this is a very important place where we need to help consumers understand their member behavior. So now with new data points, we have the ability to evaluate member behavior alongside the member's health. So the data tells us that they might be unhealthy. Then we need to understand where they're going and how they're seeking treatment. What are those behaviors that allow us to tailor a plan design and tailor a network that will complement outcomes and goals for employers? And then when we think about evaluating providers, and Dr. Shafiq commented there earlier, we now have the ability to evaluate providers at a very granular level, which will help us alongside looking at member behavior to allow us to design the most optimal out-of-pocket member costs. That would be, instead of just simply applying a broad copay, you now have the ability to apply copays in particular areas where you see particular behaviors and which you might want to design the best preferred provider outcome. And then last but not least, new data on member health including the nature of the condition and the severity of the disease, allows us to explore how less costly virtual care can complement members' experience and cost associated with both services and medicine. And finally, provider outcomes and member health connected together. So again, member health and member behaviors along with provider outcomes can help us define and develop more cost-effective disease pathways for members in the plan. And when we talk about disease pathways, again, it is my belief that over the next decade, we'll see disease pathways become a critical component to continuing to take care of our consumers, but also do it in a way that's constructive to managing costs. And so over the next three slides, the next 3 or so slides, we're going to highlight some examples of employers that have implemented various aspects of these techniques to address the rising costs that we've seen in healthcare in the last 18 months. And so with that, we'll take you to our first example. And our first example showcases the reality that was presented by Dr. Shafiq in his earlier slides. And that being that member behavior illustrates that if given a choice, members will select the top tier providers available to them, even when their conditions may not reflect the need to visit those providers and the type of provider they're visiting. Without the proper incentive and without the proper education, why would a member or consumer choose otherwise? And so this might be seen as rather traditional approach to managing cost, but in this example, this employer showed a case performance trend. That's a healthcare inflationary trend of near 12%, which is higher than what we see in generally in the marketplace, with a large contributor of that rising cost associated with provider choice. In this case, and this is where the data becomes quite granular and helpful in designing the right program, 82% of the OP utilization was what we would call top tier providers, with an average OP consultation cost of $136, which is well above the book performance for MetLife at least of $65. And in this case, an increased copay on the top tier provider while maintaining a zero copay on preferred providers, those that have the same capabilities and do so at a preferred or more value-based outcome, resulted not only in a reduction in overall utilization by 5%, but also a reduction in top tier network from 82 to 65%, and an overall OP cost per claim that dropped to $103. The overall result in the following year was the customer trend performance down near 8%. So the lesson here, again, maybe to be seen more generally, is that along with customer communication, which gave very specific direction to the employees on the choices they had from a provider perspective, including access to telehealth and OP services at zero copay, helped drive the right behaviors and the right financial outcomes for this employer. Again, we might say that this technique is rather traditional. What is different is that the data now can complement this approach by refining varying copay structures, member education, and outcomes. And so that concludes the example of the first case. If we move to the next example, plan design and member health also drive member behavior. And I think, John, if you wouldn't mind just moving to the next slide. There we go, thank you. Plan design and member behavior, as we mentioned earlier, and member health also can drive an additional layer of performance improvement. In this case, detailed data can help us optimize the performance of the plan and the health of the population. These can ultimately contribute to mitigating some, if not all, of what we've seen in recent member and provider utilization data that Dr. Shafiq presented. In our second case study here, we see how disease prevalence and the severity of disease and the member choice of the provider setting can have a significant outcome on the plan performance, one that can be reversible. So let's start with some of the statistics on this customer. First of all, the customer struggles with 29% of their OP claims associated with 3 chronic diseases: diabetes, hypertension, and musculoskeletal conditions, MSK. The customer had an existing copay of 20% on OP consultations in general. However, no copay on OP services that were rendered following a consultation. This customer had a $4.5 million OP claim fund, and the top 3 conditions, these OP claims associated with the top 3 conditions, represented a $1.3 million claim fund. Diabetes had a cost per claim of $181, and 42% of those services were rendered in a hospital setting. So I want to pause there just before I go on to the other conditions. This is where Dr. Shafiq was referencing earlier that many of the visits in the last 12 months, and certainly this was pre-COVID as well, are done in a hospital setting when they can very well be done in a clinical setting. For hypertension, the average cost per claim for OP was $157, and again, 44% done in a hospital setting. And while MSK had a lower cost per claim of $103, still 45% of the visits were done in a hospital setting. The additional layer of data studied on this group showed that of those claims of the 3 diseases, approximately 80% of the claims were acute in nature or were associated with regular follow-up, with MSK having actually 89% of the claims performed on an acute basis. These would be regular follow-ups or treatments on, let's say, ailing back conditions or neck conditions in a hospital setting, but that were determined to be acute in nature. So when you see the nature of the conditions and where people are going, you see the misalignment of cost of care to condition. And this is what I talked about earlier in terms of aligning patient pathways and developing centers of expertise with preferred providers and preferred settings that can help derive better value while still treating the patients. In this case, as a result, the recommendation was made to simply adjust the plan design to have 20% copay on hospital settings for all OP. So that means whether you're visiting a provider for a consultation or for labs or for ongoing investigations, if it was done in a hospital setting, it would incur a 20% copay, while keeping the existing consultation copay of 20% down to 0 copay in a clinical setting. So again, I mentioned earlier, instead of always a punitive change, actually making adjustments to enhance the plan design based upon member choice. In addition, a preferred provider disease management program was made available to those for ongoing care, again at a lower copay than those that they would have seen earlier, including for refills of chronic medicine. In this case, we did a comprehensive communication campaign, and the result was a 12% reduction in visits to the hospital for these particular conditions. So what it meant was members then were making the decisions to select clinics for their ongoing care. Now, not everybody could do that, but a 12% reduction was significant. And the cost of the top diseases dropped by 9%. The overall savings to this claim fund was near 400,000 US dollars, which represented a drop in the total claim fund of roughly 6.5%. So in this case, again, using clinical data and using very refined data, a more aggressive approach to designing a plan design that drives member behavior while still managing access to providers and giving employees choice. Okay, we'll move on to the final example. And this is a significant impact that's been introduced just recently around virtual patient pathways to a plan that can have a significant cost reduction if managed the right way. Earlier this year, many of you know, MetLife launched Care Anywhere, a first of its kind value-based partnership with Outpatient Healthcare Group, where members can get access to zero copay virtual care for generalists and specialists. In addition, we've enhanced where a customer's plan exhibits high member utilization in top-tier providers, as described in the past two slides. We've extended zero copay for all OP services across the Care Anywhere network, allowing members to have access to virtual and in-person medical clinics. Through data extracts, we now have the ability to review the probable impact of a claims fund more accurately. And if employers are able to promote use of virtual patient pathways with their employees, either through plan design change or communication, we can clearly articulate what that savings should look like. In the example shown here, and similar to our portfolio, over 80% of OP care is rendered as acute, whether it's chronic disease or not. This could be the common cold up to routine follow-ups for hypertension and diseases. In this example, the average cost per consultation for this customer was 97 US dollars. Again, higher than the portfolio, resulting in an OP consultation claim fund of 1.2 million US dollars. While this employer did not elect to change its current copay mix on consultations, we did implement the Care Anywhere network with zero copay telehealth visits. And in this scenario, we can now project a 3% reduction in overall claim fund for every 10% member shift to the use of the more convenient virtual pathway. So now employers can lean upon MetLife or their insurers to understand the impact that virtual care and telehealth and others can have on their plan. Example like this really is just the tip of the iceberg when it comes to leveraging virtual care and more generally preferred providers to deliver more care. I think it opens up the world for us when we think about things like virtual chronic care medicine refill programs, virtual disease management programs, and leveraging virtual care as gatekeepers. So again, this is a great example. Again, I think the tip of the iceberg as we head into the next few years ahead, not even the next decade. So with that, I've covered a few examples of where data and smart plan designs can help drive cost management. We look forward to our partnership with our partners, our consultants, and our customers in helping shape plan designs to meet the needs and expectations ahead. And with that, I didn't see whether or not any questions came in through the chat box. I'll just ask John if there were any questions that came in the question bar, because I don't see that here in my panel. John, can you confirm if there were any questions before we wrap up?
Yeah, just hold on a second, Andrew. I'm just trying to.
No worries. And if we do have questions and we don't get to them, we're going to wrap them up and get back with you guys.
Sorry.
That's okay. I won't put you on the spot. I want to thank Dr. Shafiq, first of all, and thank our audience. It's late in the day here in Dubai, so I want to thank everybody for joining. Encourage you to reach out if you have any questions regarding the material we presented or in general anything else. If there are questions, we'll get back with you.
Actually, Andrew, there is one. Just a quick. I can give you this one quickly if you want me to now.
Great, thank you.
Can you give some insights on the data on mental health? Is there a marked increase in the number of claims post-pandemic or during the pandemic?
Yeah, Dr. Shafiq, you want to take that? I'll also provide some commentary towards the end.
Yeah, thanks, Andrew. Thanks. It's a good question. And I think the last webinar which we presented, I remember we did show something onto the mental health. And at that time, what we saw is that the data was showing us 100% increase in the uptake based on what we have seen pre versus a post-COVID level. Now, we still see the same trend. And although the percentage-wise looks very, very high, but remember, in the pre-COVID time, there were, in the norm, the mental health was not getting the coverage itself. So there were very few groups who were interested into the mental health versus the post-COVID, where mental health is really becoming and coming to the limelight, and everyone is really looking forward to get into the mental health. We as a community have understood the importance of the mental health itself. Along with that, the regulators are also working into the same direction, and there are some regulations coming up in relation to the mental health as well. So to answer the question, yes, we are seeing an increase into the mental health. We have been a big advocate of the mental health. There has been some programs around it. I'm sure Andrew is going to cover it. But from a claims perspective, yes, we do see an increase into the mental health cases itself. Andrew, you would like to add some?
Yeah, it's a great question. The answer is yes. If we take a look at those customers that had a psychiatric treatment, behavioral health treatment within their plan design, we have seen increases in the utilization, let's call it. I think we would comment that it's a very important benefit. It doesn't represent a significant percentage of the claim fund. So when we presented some of those attributes that Dr. Shafiq showed in slides 3, 4, 5, you saw diseases that are more prevalent and have higher cost value in the claim fund. But when you do look at your report, when you do look at your claims report, you see behavioral health related treatments, you will see an increase just by virtue of the fact that there are more visits and more members utilizing these benefits, which I think is important. To that end, obviously, Dr. Shafiq mentioned we've enhanced and expanded the provider network across the region, and also spent a lot of time this last year and a half focused on member education, and want to certainly continue to encourage that. And I think it was good news we saw, this last month, that going into next year, behavioral minimum benefits as defined by the DHA will become part of all plans going forward once you reach your renewal cycle. So if you weren't aware of that, these types of benefits, behavioral services, will become part of all plans in the UAE going forward, and we're excited about that change that the DHA mandated. All right. Well, listen, we're at the top of the hour. Thank you guys for all of your time, your participation, energy. Thanks, Dr. Shafiq, again. Thanks, John, for putting on the show. And we hope you guys have a great rest of the week. Thank you very much.
Thank you. Thank you.